So I guess we're about to take a sharp right or left turn to go from looking at educational and juvenile justice systems to looking at program and policy level measurement within the healthcare system. It's interesting to reflect on the differences and similarities in the approaches and also in the sort of stage of evolution, and it may be worth discussing some of that. So just a question for people to think about is, how do you decide, how do you choose a doctor or a hospital, or how do you choose a therapist for your child? How do you determine whether you're actually getting good health care or good mental health care? What data do you look at? You know, as a policymaker or a scientist, do you actually look at to make those determinations? And think about that for a moment, just to think in terms of how then applies that beyond the personal level to sort of a national level. And a lot of this is really thinking about how it also fits into the healthcare reform movement. So the Affordable Care Act has within its purview a number of different elements. A lot of attention has been given to the expanded access to health insurance, but a key issue has been the degree to which it employs quality measurement and accountability for the healthcare system, and really amps that up within the context of healthcare reform, as well as some of the new demonstration opportunities as they try to integrate some of the system and payment redesign elements with quality measurement. So these are just some examples of the quality reporting and payment programs within the Affordable Care Act. And just to take one of them that focuses specifically on mental health care is the value-based inpatient quality reporting program, which earlier this year, the first report, this is a pay for reporting, not a pay for performance. Get closer. This is a pay for reporting, not a pay for performance program, and the results of that just were published publicly over the past year. And you can see that it actually has impact. So that in the Boston Globe, after this report came out, it actually talked about the overall performance of hospitals in Massachusetts, as well as specifically which hospitals performed low and which performed high. And so that there's impact and teeth in this. A lot of this dates back to a series of Institute of Medicine reports, really going back to the Errors Human report, which really looked at medical errors in the health system. This is over 10 years ago, and had a graphic. It really was picked up by the New York Times, front page of USA Today, with sort of the graphic metaphor that the number of people who die every day from a medical error is about the equivalent of a jumbo jet crashing every day, but nobody knows about it. And this was followed by a report that looked at the overall healthcare system with regard to how it assesses quality and improves quality. And they found that the chasm between the healthcare system, the quality of the healthcare system that we do have versus the quality of the healthcare system that we should have is not just a little gap, but it's a big chasm. And this was followed up, and basically they developed 6 domains for how we think about quality. That it should be safe, effective, patient-centered, timely, efficient, and equitable. And these form sort of the domains or bins in which we put different quality measures as how we think about measuring quality. And subsequently, there was another report that actually looked at how do we apply the system redesign elements and principles that were suggested in the Quality Chasm report for mental health and substance abuse, including care for children. And basically the conclusion is that we have a very shaky bridge for crossing that quality chasm. The committee identified a series of obstacles that are particularly an issue for healthcare for mental health and substance abuse conditions. And I'm going to talk just specifically about the weak measurement and improvement infrastructure. Basically, what the findings were for the committee was, number one, that clinical assessment and treatment practices are not well standardized. And they're also not well classified for use in administrative data sets, so that data about the kinds of care that is being provided, the kinds of characterizing the kind of conditions that are being treated, and characterizing outcomes really is not readily available. Number two, we don't really use outcomes measurement in our clinical enterprise. And even though we had actual reliable and valid instruments. And the concept of measurement-based care, which I'll talk about a little bit more. And Sarah, by the way, is going to follow me and talk more specifically. I'm giving kind of a 30,000-foot overview of what might be termed the sort of quality measurement industrial complex. So the measurement-based care approach is something that we'll talk about a little bit more. Number 3 is there's not enough attention to the development of performance measures for mental health and substance abuse care, and especially for kids. In addition, using those measures to improve quality has not really permeated the day-to-day experience of mental health services. The workforce is not trained, is a very heterogeneous workforce, which also presents obstacles, but even across all of the different disciplines involved, there's not really a strong component for training people in quality measurement and improvement. And finally, our policies, at least up at that point in time, really weren't effectively incentivizing quality and efficiency. That's changing, as I mentioned earlier, with the Affordable Care Act. So this is just a report from Bonnie Zema and her group at UCLA, looking at the quality of publicly funded child seriously mentally ill care in California. And this, utilizing sort of a combination of administrative data and chart reviews, found basically that performance was not great. And Sarah is going to go into more detail about some of those things. Now, in the Affordable Care Act, one of the requirements is that there actually be a national quality strategy to implement better measurement and better improvement of quality. And as I mentioned earlier, there's a whole list of different quality programs within CMS, which actually include sort of quality reporting for both Medicaid adult reporting as well as CHIPRA quality reporting. And that there are committees that review the quality measures, that endorse them, and I'll talk a little bit about that whole process. So it all comes down to what kind of measures we have and how do we develop measures, and what's the database for doing it, and what is the methodology by which things get processed through the system to become a measure that's used in a federal program. And the model that really was proposed in terms of thinking about this from the point of view of at least the Quality Chasm report is to think about really developing a kind of integrated process that utilizes, doesn't seem to be working too well, but that utilizes representation from consumers, from clinical and administrative leadership, across mental health, substance abuse, and primary care, that there has to be a linkage between those. In fact, the main recommendation from the IOM report in 2006 was, number one, not only do the quality principles and quality chasm principles and system redesign principles for the quality chasm report apply with a vengeance to mental health and substance abuse, but also we can't separate mind and body, that has to be an integration and a linkage between mental health and general health care. And I would add also linkage to social services, educational services, juvenile justice across these different elements. And the way in which one approaches this is, number one, you have to have some standardization of practice elements, both at the assessment stage as well as at the treatment stage, that's able to be collected and characterized within an IT infrastructure. And then you have evidence-based guidelines that assemble those elements into sort of pathways for how one would administer the optimal care. And then you have ways of measuring whether that is in fact going on in terms of measuring performance. But then you don't just measure, you actually use the measures to improve performance by teaching people how to do quality improvement using various industrial engineering principles, and reward them. And to think about how we share accountability across these different domains of primary care, mental health, substance abuse, and for that matter, the educational and social service systems. And then do this in a way that continually strengthens the evidence base so we continually improve the system. So in terms of measuring performance, basically the notion is you can't improve what you don't measure, and the developing of quality metrics that are across the IOM domains, but also think about the difference between accountability versus improvement measures, and that there's a higher threshold for accountability measures where there's skin in the game with regard to public reporting and payment. And to do this in a way across these different silos and at multiple levels, and really not distract people by having too many measures that don't focus on the important things. So to think about it from the point of view of measurement levels of patients, is sort of 6 Ps: patients, providers, practices or delivery systems, health plans, public and private purchasers like Medicare and Medicaid programs or employee benefit managers, and at a population or policy level. And so there were basically, people think about 3 or 5 different types of measures. One is structural measures, looking at whether there's the capacity, adequate personnel, adequate systems, adequate infrastructure for providing effective care. Number 2, process measures, whether these evidence-based processes are actually being conducted with fidelity. Does what is being done in practice look like what was done in the literature that provides the evidence supporting those practices? And do people have access to those services? Outcomes, looking at, does the care really improve outcomes? We also want to know about the patient experience and also things about efficiency as well. So there are different steps in how you develop indicators. Start with establishing an evidence base, translating the evidence to guidelines, translating guidelines to measure concepts, and then operationalizing those measured concepts. So if you're thinking about sort of adequate follow-up care for kids with ADHD, how are we defining ADHD? What's the denominator? What source of data is being used for capturing that information? For the numerator, how many visits are adequate for follow-up over what period of time? How do we measure those visits? What's the evidence about the different thresholds and benchmarks that we're using? Then testing that for reliability, validity, and feasibility. You don't want to spend more money on collecting the measures that I'm providing the care. And then aligning the measures across multiple programs, because you saw that there's almost 30 different programs under the ACA, some of which are measuring similar things but with somewhat different concepts or somewhat different operationalized components. And then making sure that there's some stewardship to the measures, that they're updated over time as new evidence comes in, as we find out more about how the measures perform. And so people think about having different components, a numerator, a denominator, exclusion criteria, trying to standardize the collection of that data, and also, particularly for outcome measures, developing risk adjustment models. And actually, there's a report out from a committee from the National Quality Forum now looking at whether or not there ought to be some kind of risk adjustment based upon socioeconomic indices for process measures as well that people are thinking about. Gathering data for indicators, which is the typical sources are administrative data, particularly insurance claims, chart reviews, utilizing people to abstract information out of charts or doing it through fields or natural language processing from electronic health records. Increasingly, people are looking at developing registries that include longitudinal follow-up information on outcomes, and also patient surveys. And there's a whole set of issues around making sure that that data is accurate. And also, the hard part is determining what should be the benchmarks, what rate is right. If you're looking at adherence to certain types of medications, should everybody be 100% adherent to all their medications? Or is there some element of patient preference and other kinds of issues that need to be taken into account? And so there are different players in the measurement process. There are the evidence developers. So when the National Quality Forum puts out a call for measures, it goes out to measure developers who then have to provide a lot of detailed information about the measure. And this ranges from people who are developing, so the evidence people who are developing the evidence underlying the measures are researchers, people from NIH that are funding it, PCORI that's now funding some of these issues to know what works. Guideline developers are largely professional associations and other organizations that develop guidelines, whether it's hospital groups or even or national associations like the American Psychiatric Association, American Psychological Association. Measure developers are people who actually propose measures for adoption or endorsement. And then there's measure endorsers, which is particularly the National Quality Forum, which is to some extent instantiated in the law as a measure endorser. And then once a measure is endorsed, it doesn't necessarily mean that it's actually going to be implemented. And then there's measure users. And just the criteria for measure endorsement are largely that the importance of the measure, the scientific acceptability, the usability, and the feasibility of the measure. And then, as I said before, we want to use measures, using it at the clinical level to make sure that people are getting measurement-based, patient-centered care. The use at the organizational level for improvement, and using it at the policy level for accountability, both public reporting as well as for payment. So there's a number of issues around using behavioral health, developing and using behavioral health measures. The limitations of our evidence base, the degree to which we have the health information technology that's integrated in a way that can actually capture data routinely, the way we codify psychosocial interventions. Typically, the current procedural terminology, all we know is that somebody got 45 minutes of psychotherapy and we have no idea what's inside the black box. The question of documentation versus reality, determining benchmarks and risk adjustment. Linking the assumption of structure, process, and outcome is that there's a sort of a linear causal association, but that may not be the case. In the Accord study for diabetes, diabetes is kind of like the poster child for quality measurement. The idea was it went from, did somebody get a foot exam or an eye exam in the past year, to did they get a hemoglobin A1C measure, then to the value of the hemoglobin A1C measure, what proportion of your patients are below 9, below 8, below 7. Then the Accord study comes out and shows that mortality is greater for people below 7. So then that's, because it's a heterogeneous group, and how do we apply it in a more personalized way? The issues of stewarding and funding measure development, the implementation of health information technology, the heterogeneity of providers that I mentioned before, and really getting to the point of who is accountable for performance. You have a lot of players, and how do you hold them accountable, and what sort of shared accountability is necessary? And I'm just going to end by pointing out this whole concept of measurement-based care that is really systematically applying standardized clinical measures and then assuring consistent longitudinal assessment, sort of ruthless follow-up, with action-oriented menus for improving and intensifying care, and creating a practice-based infrastructure that allows one to build this into the system in a routine way. And one of the things that's been done, and a lot of the things we just heard about in terms of the educational system and juvenile justice system, is building essentially an infrastructure of structural measures with associated process and potentially outcome measures into a system. And that's something that's being looked at within the healthcare system as well, through patient-centered medical homes and other similar types of organizations. And Sarah is going to follow up, going into more detail about some of these issues.